approach in a case of obesity, most likely in the exam, the case scenario will be syndromic. That is most likely. But some of the other cases may be also there, like simple obesity. So if we know the basics of obesity, the basics pathology, so that will be easier to investigate as well as manage the case. And if it is a syndromic child, then also this obesity, the management part actually will be little bit of similar way, but like the thing which will differ the investigation part because of particular basic like diagnostic investigation. Suppose if this is the Prader-Willi syndrome or Barber-Biddle maybe or Downs maybe, then some of the investigation will be some of the definite investigation. But otherwise the investigation and management part are basically a little bit of similar pattern. Okay, so we need to identify or know the basics of obesity that will help us in all the pattern like obesity related cases. Okay, so we will discuss the obesity little bit after this like approach. Okay, so first introduce yourself with the examiner as well as to the patient and to the child. So here the important thing is talk to the child. So after like have a just like after
entering the room and
entering the room, if you see the child is little syndromic, you seems to be syndromic, then it's always necessary to talk to the child because some of the intellectual impairment may be there if the child is Prader-Willi, Barber-Biddle, Downs, or maybe in undiagnosed case of hypothyroid. Okay, the presentation, if this is first time, then maybe some of the low IQ will be there. So it's always better to talk to the child initially. So that
what is this Pickwickian syndrome? I don't know that.
Okay, yeah, I will go. I will discuss. Okay, fine. So some of the like sleepy child, if it is there, then it is like Pickwickian syndrome. That is rare variety of hypoventilation. Okay, because of they are more habitual. I mean that of related to high PCO2 level in their blood. If we do an ABG, that will show high level of PCO2 as well as some of the renal compensation of high bicarbonate. So this kind of obesity, the child will be little sleepy and the respiratory rate sometimes will be slow. Okay, so that is not common actually, but if we know that will be better. Okay, now general inspection, all we know 4DS dysmorphic, there is Prader-Willi, then Barber-Biddle or Moonan like Lawrence Moon, or maybe some other like dysmorphism may be there. Okay, like Downs and others. But at the same time, in general inspection, we can see the growth parameter. Definitely the child is obese. So we need to assess whether the child is short or tall. So according to this area, we need to comment on like growth chart. So I like if this is tall with obesity, maybe Klinefelter, or if this is short, maybe there is endocrinal or some of the other syndrome. Okay, so this area height is very important. Mostly if this is short stature, then some of the endocrine causes may be associated with the same syndrome or maybe the case. Now head circumference, some of the cases they say it like hydrocephalus with spina bifida. If they are like having unable to walk and the sedentary lifestyle sometimes may lead to this kind of picture. Okay, high head circumference, large head circumference maybe with obesity. Now the important area why I just made it like BMI and weight. This is the key actually. Okay, if we don't mention the BMI in obesity, that station is incomplete, as you all know. Okay, now weight measurement as well as BMI we will discuss in a growth chart how to plot the BMI. Now respiratory rate. So Even some of the cases like hypoventilation syndrome, like Pickwick, like Pickwickian syndrome, the respiratory rate sometimes may be slow. And some of the other cases of obesity, if the child have any kind of respiratory problem, then respiratory rate may be sometimes high. So it's not always like will be, a distressed child with respiratory distress in the clinical examination. This is very unlikely, but we need to know actually. Okay. Now the hands. Hands, we will begin from the hands as we discussed previously. That hands are, if this is small, sometimes is a significant of preservative, and sometimes we need to see whether any extra digit is there or not. Some of the scar may be also there, because suppose this look at my hand. Actually, if there is any extra digit like was there and that has been removed, so the scar will be here, okay, or maybe some of the other places where the extra digit has been removed. So not always the like extra digit will be there if the case is barbed brittle. Okay, so some of the cosmetics reason maybe that has been removed. So if during our examination of the hand, if we see any kind of scar is there, we need to think that maybe this case is like barbed brittle, or maybe pseudo hypoparathyroidism, or that's what, like other, for some cosmetic reason this has been removed. Okay, so pulse again, if this is hypothyroid, the pulse may be slow, bradycardia with hypovolemic, and bounding if this is like if there any kind of hypertension is associated with this, then high volume pulse sometimes will be there. And BP is always important. We are going through the hand, then after examination of the hand, pulse, then BP, then axilla for puberty as well as lymph node, and we will move upward, neck, face, then head to toe. Okay, in this way. So what will be there in the face? If this is a moon face, there is chances to get it like pushing syndrome. Eyes, if there is any dysmorphism with squint or sometimes wearing glasses, there's Lawrence moon or maybe valvular, because this kind of children may have some of the problem with the vision. Okay, so that is there is chance. So we need to see over the eyes. Now, looking at dysmorphic features, sometimes that will be more prominent over the face. Now, in the neck, thyroid. So, if there is any kind of thyroid swelling, that will be more prominent during our examination. Or if there is no thyroid swelling or having some of the scar, then we can identify if there was some of the thyroid surgery has been done previously. So we need to identify this neck scar in front of scar. Okay. Now acanthosis nigricans, which is the significance of having this insulin resistant. Okay, that can be assessed over the neck. Okay. Now chest and cardiorespiratory, for some of the loud like second heart sound. If this is present, then we can assess or say there is some of the pulmonary hypertension may be there. Okay. Some of the right ventricular hypertrophy as well. Okay. Now in the chest, gynecomastia. Why gynecomastia in cases of obesity is significant? Can anybody tell that?
Klinefelter's can have
Klinefelter's.
gynecomastia.
Exactly. So Klinefelter syndrome, which is tall, or maybe with gynecomastia as well as, and any other finding and other significant finding in Klinefelter that will be more prominent in the case. Any other significant finding? Can anybody tell?
Intellectual impairment.
Sorry?
Tall.
And any other most common presentation? Most common intellectual impairment. Yes, yes, and
tall,
and
obese,
and delayed puberty. There will be no axillary hair, scanty, pubic hair sometimes, like sometimes cryptorchidism maybe. Okay, so this kind of feature will be there. Now abdomen. Again, if this is pushing, then some stria may be there, some scar like hernia repair scar, peritoneal dialysis scar, why this say peritoneal diagnosis scar? Can anybody suggest? Peritoneal diagnosis scar or peritoneal dialysis was needed for? Yes.
DRM, chronic renal failure.
Chronic renal failure. Exactly. So renal scar, as that is Lawrence Moon, we need to palpate the in every obesity cases there is chances of hepatomegaly or like enlarged liver because of fatty liver changes. Okay. Now adrenal masses sometimes may be there because of Cushing, that they're causing peripheral cause of Cushing syndrome, which is adrenal mass which is producing the high level of cortisol. So adrenal mass sometimes on palpation may be, some of the cases may be present, and genitalia, we need to examine the genitalia as well to look whether any hypogonadism is there or not, which is significant in Prader-Willi as well as Kalaman as well as Glenfield. Okay. Now back is a must. Back is definitely, we need to assess the back, because otherwise some of the finding may be missed. Kyphoscoliosis may be present. Okay. Buffalo hump, which is called like pad in the back of neck. Okay, that may be present in Cushing's. Scoliosis, if present, then we need to ask the child to bend down. So we need to assess whether any kind of disappearance of like a feature, the scoliosis is there or not, so that we can come to a conclusion. Otherwise this pushing or some of the spina bifida, if with obesity, then this can be missed if we do not examine the back. So back is really important. So middle, okay. Now midline scar, if it's there, then repaired meningomycin sometimes. Now to complete my examination, this area is again important. Why? Because some of the obese children, for this weight, for this like weight and this obesity, some of the chances of getting slipped upper femoral cases. Okay, so there may be antalgic gait, or some of the proximal myopathy is when visible, then we can ask the child to just sit down and just get up from me. Okay, so that will be difficult for a patient with Cushing syndrome who is having also proximal myopathy. Now at the end, we'll also inspect the feet for any small fingers are there or not. Okay, so all these features is important, but at the end we need to assess whether any ankle edema is there or not. If the child is in failure, right-sided failure, then that is also possible. But in obesity, that is difficult. But if there's gross swelling, then definitely the edema can be assessed with, like whether it's fitting or like edema is present or not. Hip examination, if time permits, and if any kind of other abnormality is present during our examination, like gait, then we can proceed for the next, if time permits. So it's very unlikely the time will be there to examine detailed hip examination. And they said reflexes sometimes is like reduced in hypothyroidism, but the time, I think, will be very short. So that if examiner asks what are the other examine you want to do, then we can at least say, if we know that yes, these are the areas. Okay, so that is basically the approach. The previous day we just discussed the same thing. Now we'll move case practice different. We have 4 or 5 cases, so we will discuss quickly as a practice session. After that, we will go to know the basics of obesity, and after that we'll discuss the guidelines. That will be easier. Okay, that will be easier, okay, to understand. So now I will share the first case. So actually I need 3 or 4 people or maybe a 5 to practice this session so that everybody will participate and we will like move quickly. Okay.
I want to do one. Anyone.
Okay. Okay. So this is our first case. That is Karan, who is 10 years old child. 10 years old boy. Kindly examine him generally. Okay. So this is your task in clinical station. Kindly examine him generally. Okay. So take your time. After that, we will discuss all these cases together one by one. After that, we will go to the basics of like obesity, which is related to the complications. And after that, we will go to the guidelines to know how to manage a case of obesity. And after that, we will discuss the growth chart. Okay, that's today's plan actually. Okay. So if you are ready, then you can start.
I'll start.
Let me keep the time, please. So Dr. Manisha, I think she connected now, no?
Yeah, I'm there.
Okay, fine.
Yeah, I don't know. There was some problem with my laptop, so I was not
Maybe
able
I
to
have
connect
just
it.
closed the meeting. After that, we connected so that the problem can be solved. But maybe that was your side, some of the problem. Okay. So your time. Are you ready, Dr. Neha?
Yeah.
So your time starts now. Please start.
I'm entering the room. I'm washing my hand. Hello, my name is Dr. Neha, one of the pediatric doctors. How are you, Karan?
Yeah, Karan is fine.
Okay. Is it okay if I examine you today?
Yes, sure.
Okay. If you have any pain during your examination, let me know. I'll stop. Okay.
Sure.
So I'm going to get a good look around. Is there any medicine or any IV line or anything that I can see?
Nothing.
Any hearing aid? Nothing. Okay, so Karan looks like a well child. He is well grown for his age, though I would like to plot his height, weight, and head circumference on the growth chart. I would also like to plot the. I would also like to calculate the body mass index for this child. Is there any dysmorphism that I can see? Because when I'm looking at him, it doesn't look dysmorphic.
Okay, there is no dysmorphism.
Okay, so I'm going to start by Karan. Can you show me your hand?
Yeah,
is there any pallor or
showing.
any clubbing there?
No pallor, no clubbing.
Okay, any extra digit or anything there? Nothing.
No,
Nothing. So I'm going to feel the pulse. Is the pulse regular on both sides?
Okay, regular.
Okay. I'm looking at the skin. Is there any dry skin or any eczema or anything I can see? Nothing is there. Then I'm going up. I'm going to go to the axilla. Is there any axillary hair that I can see?
No.
Okay.
There is this few of the very tiny.
Okay. Any acanthosis that I can see anywhere in the armpits or in the neck? No, nothing is there. I'll just feel the lymph nodes. Are there any lymph nodes I can palpate?
No.
Okay. Can you, Karan, can you say ah for me? Is there any abnormality in the mouth?
Okay, no.
No. Any abnormality in the eyes when I'm looking in the eyes? Any abnormality, any squint or anything?
Okay, so no, there is no squint.
No. And the ears are also normal, right? The ears and the nose, everything is normal. Okay. So now I'm going to okay. And did you say that there was acanthosis? I forgot actually.
No, negative.
No acanthosis. Okay. So I'm looking at the chest. Is there any gynecomastia or anything there?
No, not exactly gynecomastia, but he is little obese, so that's why there is little prominent both the.
So, Karan, can you turn behind? I want to look at your back also. Is there anything on the back? Any
No,
scoliosis or anything? Okay. Okay. So, Karan, I'm just going to look at his chest. I don't see any deformity. I'm going to listen to the heart sounds. Are the heart sounds fine? Any murmur?
No, ma'am.
Okay. Now, Karan, can you lie down on the bed? I just want to feel your tummy. If it pains you, let me know. So, I'm going to warm my hands and palpate for the liver. Is there any hepatomegaly?
Yes, liver is 2 to 3 centimeter below the first margin.
Okay. And non-tender. So, I'm going to palpate for the spleen. Is there any splenomegaly? Any other mass I can feel anywhere? No. So, Karan, can you walk across the room and come back and show me if you can walk properly? Is he waddling or is he?
No, normal walking.
He's walking normally. Okay. So now I'm going to take permission from the examiner and Karan. Can I see your genitalia? Is that allowed?
Okay, no need because genitalia is normally developing.
Okay. So just to complete my examination, I want to take the blood pressure also because I have not taken the blood pressure so far. And I would like to plot the height, weight, and the BMI on the growth chart. Also, I'm going to look at the parents. This is important. So I'm going to look at the parents. Are the parents obese or dysmorphic?
No dysmorphism. Parents are normal.
They are not obese either. Okay. So, okay. So, yeah, I think I've completed my examination.
So yes, you are very fast. It's about 4 minutes and 40 seconds.
My God, I missed something, is it?
No, this is because there was minimal finding.
Okay, okay.
That's anyway. So what are the things? Sometimes in obesity like cases, there may be short stature with obesity, tall stature with obesity. So here, this was simple obesity.
Simple obesity, yeah.
Yes. So most commonly, this is because of like food habit or sedentary lifestyle, maybe. Okay. So the thing is, we need to go in a like maintaining the structure. That's why this was our first case. So you did really well. First thing, we need to like after interviewing, taking the permission and we need to observe the child. General observation. So what general observation show? The child is not non-dysmorphic with apparently normal, well grown actually. And if we comment in any area about the growth, whenever we are commenting that this child is well grown or not well grown according to his age, then at the same time we need to comment over the meet parental height. So suppose the child is short, and at the same time, if we do not comment on mid parental height, so our interpretation is incorrect. Why?
Okay.
Why?
Because if if his growth potential is going to fall within the mid-parental height, the parents are also short, then he's not really short.
Yes. So if the parent are already short, the child genetically will be like growing according to the father and mother, maybe with the parents. So in these cases, overall assessment, general assessment, if we see the child is short, then it's difficult to say that the child is definitely have short stature because we don't know about the parents. If the parents are also small, there is chance to, the child is maybe also small. So that is very difficult to say, or it's totally wrong information if we say the short child without assessing the parent. So that's why means parental height is always important. So whenever we will comment over the growth and height parameter and all this head circumference and weight and height, at the same time we need to comment with mid-parental height. We need to check the height and weight of the parents. After that, we assess and put on the growth chart. And after that, we can say this is a short, okay, short child. So that's why mid-parental height always it need to mention whenever we are mentioning the growth parameters. Okay. Now,
What I missed in this child is Goa sign. I didn't do the Goa sign.
so if you miss Goer sign, and apparently simple obesity, that is like not so much of like if you miss in a child of Cushing syndrome, where the prominent feature of myopathy is there, just thin limb or maybe that will be more significant. Okay, they will mark you down at that area. So you can check definitely. Now, pivotal assessment. During pivotal assessment, you checked the axilla and the genitalia as well. Okay, so initially you forgot. I think rest of the no, after that during completion of your examination, you will just improve it. Otherwise, I think in the lower limb, we should also look for any kind of digit abnormality is there or not. Okay, so that part in an inspection, but we need to go from the hand, then head up to toe. Okay, in that fashion. And according to obesity, we will discuss this later part of this 4 or 5 cases. This practice session is first. After that, we'll move. Okay. So this was our first case. I'm not going into that investigation and management part right now because most of them are basically the same. Basically, it's the same, but few are the added thing will be helpful after discussing these cases. Okay. Now, I will move for the next case. So anyone, need to participate at least so that everyone will be helpful. I mean, if this is the area, if we it's like this, that will be more easier actually. Okay.
Pranab, you can do, I can give you the findings.
Okay, that will be great. So someone please again keep the time. Someone please keep the time.
Should I keep?
Okay. Thank you.
Okay.
Pankaj,
When you are ready, you are ready, tell me, huh?
okay, so I'm ready.
Yeah.
Okay.
Okay.
Okay, go.
Okay. So I am entering the room and introducing myself that I am one of the pediatric doctor here, Dr. Pranab, and I will just for taking the permission of the examiner as well as the mother, I will talk to the child to taking I would like the permission. Hello, Rocky. So how are you?
So he's not talking, he's just looking and smiling at you.
Okay. So at the same time, I will just ask few more questions. So do you have any friend, Rocky? Are you going to school nowadays?
So he's looking at you and he's saying no, he doesn't have any friends.
Okay. So now it's I will take the permission again from the examiners. Is that okay if I examine him? I mean, do you I think any kind of pain is there or not? I will just ask the parent maybe if the child is not responding.
Yeah.
Sorry.
It's not you, you go ahead.
Okay, fine. So after that, I will observe the child from the bed whenever the child is standing, and at the same time, I will look for any kind of devices is there or not, and I can look there is some form of dysmorphism is there with gross like obese child and which is like not well grown according to the age. The height is less basically. So yes, so the weight is a little bit of more. So I will put all this finding in a growth chart according to the age, that is age appropriate growth chart, height, weight, as well as head circumference. And I will take the, like mid-parental height and compare with like height. At the same time, I will ask the child that can you show me both of your hand, please? Okay, so I can see there is a very small hand. The fingers are compared to the arm. The fingers are small, and there is no extra digit. There is no contracture or swelling, or that is just only fat distribution is there. Then I will ask the child, can you do like this? Do you have any problem during your movement of this hand?
No, no
No.
problem.
Can you do like this? Okay,
No
this
problem.
is just basic screening. Now I will just assess the pulse. So is there any like abnormal pulse?
No,
Like,
it's normal.
okay. Then I will move little up and assess the blood pressure at the same time, but at the end. Okay, to check maybe some hypertension may be there. So now I will at the same time assess the axillary hair, whether axillary hair is there or not.
There's
And
no
some
axillary hair.
Okay, fine. So at the same time, I will check whether any lymph node is there or not.
No.
No, I will just move little upward. So whether any cervical lymphadenopathy is there or not.
No.
No. Now in the face, what any hearing aid?
No, there's no hearing aid.
So is the child is able to see or like any visual problem is there or not? Any cataract is there or not? No.
No.
No, any runny nose, or I will ask the child to open up the oral cavity, so any abnormality, high arch palate, or maybe any deformity, cleft palate, maybe any other finding, ulcer, or gum hypertrophy, or any dental problem is there or not. All this is I will observe. So no adenoids, sorry, it's difficult to say, but tonsils. Okay, so maybe a small airway will be there. Anyway, I can see the like dysmorphic faces with round faces, and some of the eyes, there is almond-shaped eyes, which is like there, and there's a vermilion line is like not prominent. So, and mouth is just slanting, downward. Okay, these are the features in like face. And now at the chin, there is kind of fat is there, and neck, I will check for thyroid swelling, any scar or something like that is there
Nothing
or not.
is there.
No, nothing. Now it is chest. Before that, I will also check the back. So any kind of abnormality in the kyphosis, scoliosis, any scar, or
He has
any
mild
other
scoliosis.
mild scoliosis. Okay, great. Now I will come to the chest. So as you can see, there's lot of fat distribution. So is there any abnormal pulsation or not? And quickly, I will assess the heart sound, basically the S2 or maybe the loud P2.
There's a loud
A
P2.
loud P2. Well, fine. So now I will move for the abdomen. So abdomen, is there any kind of hepatomegaly or any organomegaly is there or not? As
There
it's
is
difficult to
hepatomegaly.
palpate this is a large distribution of fat. So
There
is
is
there,
hepatomegaly. It's 3 centimeters below the costal margin.
okay, fine. So all over this fat distribution, I look for any stria is there or not, because this is obese child. And
No
status
stria.
of the skin is dry or like or any like purplish stria or something like that is there or not.
No stria, but his skin is dry.
Dry. Okay, fine. Now again, I will look for. I forgot that any acanthosis or insulin resistant marker is there.
No,
or
no.
not.
I said no
fine.
acanthosis.
Okay, so thank you. So now I will look just little down to look the genitalia after taking permission of the child. So is that possible?
Yeah, it's possible.
Okay, so I can see there is like gonadism is there, and I will just ask the child to walk now. Is that okay for the child to walk?
So he's walking like this.
Okay, so there is some anti gait. Okay, so I will just ask. I will see the legs with the small fingers is there as same with like upper limb, and I will ask the child to get down and just stand up for me to check the map.
6 minutes up.
Okay, thank you. It's over.
Difficult. Yeah.
Okay, fine. So I have today examined this 12-year-old Rocky, who is apparently looking like overweight, and there is some of the striking feature of dysmorphism in the form of this almond-shaped eye, and some of the what I mentioned during my examination, the vermilion line is not so much prominent, and along with both the lips are slanting down, as well as some of the frontal area is a little bit of large, and fat distribution all over the body, small fingers and hypogonadism, and there is no other stria or thyroid swelling is there. Together, all this fine, and he is also having a little bit of high volume pulse or loud P2, along with gait abnormality, which is significant of hypertension in this child, along with this gait, which suggestive of some of the pathological process is going on in his hip joint, maybe because of this obesity, some chances of getting slip femoral epiphysis. So my most likely diagnosis is this child of Prader-Willi syndrome as my first DD, and second maybe hypothyroidism. I need to check for this, and the third is most likely maybe some of the other hypothalamic cause like growth hormone deficiency, those are midline, that of hypogonadism is also there. These are the data.
So what? So how will you investigate this child?
So my investigation will include the cause, identifying the disease, as well as the complications of the disease. As this child is obese, so for this diagnostic investigation will be some of the chromosomal studies, which will confirm my diagnosis. But at the base level, I will do some of the basic blood tests to rule out some complications like diabetes, the urine dip, as well as blood sugar, thyroid status, like thyroid function test, liver function test. Sometimes there is an enlarged liver, the liver enzyme can be elevated. At the same time, if there is high blood pressure, then I need to do some of the lipid profile. There may be abnormality in the lipid profile as well. And if possible, then after taking opinion of cardiologist, we can do an echocardiography as also. So these are the list of investigation, and anything I left,
We'll talk about that in the end. So if you have to take a targeted history in this child, what is the targeted history that you will take in this child from the mother?
Fine. So that is the most significant history I need to know. That is the birth history, weight, as well as the behavior. Was the child floppy, or is there any kind of feeding difficulty was there or not? At the same time, after that, what happened? The child is, sometimes this child may have the features of hyperphagia. And forgot, I think.
That's okay. We'll talk in the end. So what other history will you take? That's fine. So how will you manage the child? If you have to manage the child, how will you manage the child?
So management again depends upon the complications. So in this child, that is most likely developing obesity is related to some of the cardiac complications maybe. So I will do the basic blood test, and I will take the opinion of cardiologist. So any medication is needed. So this kind of children may have the chances of getting diabetes, type 2 diabetes and insulin resistance. So at that point of view, after taking all the investigation, I can manage with the help of endocrinologist. And if there is any kind of growth hormone deficiency, then endocrinologist will again help. So that is the indications early. Even this child is 12 years old, it's unlikely that will helpful in this condition. And if there any kind of ENT problem during snoring or sleep apnea, so that can be managed with ENT specialist. And for this hip abnormality, we can take the opinion of orthopedics to manage this hip abnormality. And if there is any eye problem. Though here there is no vision problem, and if the child is the IQ level sometimes may be low, or we can manage it with a psychologist or maybe some other support group and the special like learning session and developmental pediatrician for if there is any developmental delay along with this.
So if there is one feared complication in this child, what is that feared complication? What is the most feared complication in this child, this syndrome?
Okay, so sleep apnea related to sudden cardiac arrest.
That's correct. Sleep apnea related to sudden cardiac arrest is the most feared complication in this child. Well done. Is the time up? I don't know.
It's more than like, yeah, it's up. And you just give me the feedback.
Yeah.
That will be really helpful.
I think that you did everything very nicely, very systematically, but you did not mention BMI. I was listening very carefully. You said height, weight, mid-parental height, everything you said, but you didn't say BMI. It's okay. That's why I told you I'll give you the findings.
So that's why this practice session. Okay. So
Yeah,
thank you
that's
so
all.
much. Thank you.
So
Definitely.
apart from that, you did everything very well.
Whenever like telling everything that these things we need to do again, whenever the case is in front of me, again I follow. So anyway,
That's okay.
with this repeated practice, that will come automatically. Okay.
Yeah.
And during our management part, I also forgot to mention that is this pivotal delay is there. So endocrinologist maybe, I really don't know what kind of management will be helpful here, but endocrinologist will definitely take
At
care
this
of all
age,
this.
nothing. So another thing you didn't mention is a geneticist in the
Geneticist,
approach,
yes.
because this is a 15q
Yes.
problem. No? So then you have to say that I will involve the geneticist as well. So geneticist you didn't mention. And during history, the most important history in Prader-Willi will be failure to thrive in the first year of life. They will be very small in the first year of life, and after 2 years, they will start eating a lot. So hyperphagia.
Yeah.
So you also did not mention dietitian in your approach, because dietitian will play a very important role in this child. Okay.
Exactly.
Everything else you said, I think everything else you did well everywhere.
But again, we need to practice repeatedly.
Yeah, so I think you'll have to also mention about doing a polysomnography. These children, all of them undergo. So I think that is in their protocol.
Yes, definitely. That is given in the guideline also.
Yeah.
Yeah.
Polysomnography.
Sleep study has to be said.
Yeah.
Sleep study, cardiac evaluation. That is very important in this, because they can have pulmonary hypertension because of the obstructive sleep apnea.
Yes.
So cardiac sleep study is very, very important in this child. And the most feared complication in Prader-Willi is obstructive sleep apnea. It can kill them instantly.
Yeah.
Any other feedback, guys?
And I think about the reason that we want to start. One is sorry, something is wrong with my laptop today, so I'm not able to open the video. I don't know.
Okay, no problem.
I hope you're able to hear me now.
Yeah.
So I think the reason before starting growth hormone, because this is one of the indications for starting GH. So all these patients, so they undergo sleep study, and then they are scheduled for starting growth hormone. And also because these kids might have a lot of problem with feeding, they have a lot of problem with feeding, swallowing. So many of them, so you would like to take their opinion as well. I think
Can I say something?
Yeah.
This growth hormone, Pranab, in Prader-Willi is not given for growth hormone deficiency at all. These children do not have growth hormone deficiency.
Yeah. Basically, can I say
for the
here?
metabolic benefit.
Yeah, and increase weight as well as increase the muscle strength, muscle mass.
So it is not given for growth hormone deficiency.
No, I didn't say that. I said like it's
No, I'm telling Pranab because he said it.
Okay.
Yeah. So if even the epiphysis has been fused, so we can use over this case.
So you said one of your differential diagnoses was one was Prader-Willi and one was hypothyroidism. Okay, so in a 12-year-old, how do you expect the hypothyroidism to be like different?
That's why I keep it as a DD actually. Okay, because most common cases will be your first or second line DD. So
No,
that,
I'm asking you, how will you differentiate?
okay. So there will be dry skin, okay, and bradycardia sometimes during the clinical examination. At the same time, if you ask the history, there will be some of the constipation as well, and the child will be lethargic.
The child looks very dull, and the Prader-Willi is, even though they are delayed, they are like they're able to sit and do, and they're quite engaged.
Mhm.
They have learning disabilities as well. So developmental
Yeah,
pediatrician is very
developmental
important. Like
disability.
you rightly said, you rightly mentioned that it's very, very important.
So I think, okay. Any other feedback or anything we left so that we can move for the next one?
I think you've covered everything else.
Yeah, you covered very well.
Okay.
The second thing I want to say is that I think in your first DD, I would say that I would consider other forms of syndromic obesity like Bardet Beetle, even though there is no feature of polydactyly or whatever. So hypothyroidism shouldn't come as your first DD because this child does not from any angle look hypothyroid.
Yeah.
So first should be other causes of syndromic obesity. Then should be your hypothalamic, like you rightly said, and last could be your hypothyroidism, but it is very unlikely. Can say that.
Yes, you are right. Because hurry, and I was really unable to think. So that's
It happens to everybody, no?
Yeah.
It happens to everybody.
Yeah, you need to practice. You also practice. That is very important.
That's why I told you I'll give you the finding.
Yeah. Thank you so much. Okay, we'll be taking this next case.
Pranav, if nobody's taking, can I take Pranav?
Yes. So, just a minute. Okay. So Arun, who is 10-year-old male child, kindly examine him. And here is Arun. And I am giving you just 1 minute. Okay, just 1 minute to prepare yourself. Not even less than 1 minute. Okay, just prepare yourself. I'm just coming back. Okay. Okay, so are you ready?
His name, what did you say, Pranav?
Arun.
Arun. Okay. Okay. So I'll wash my hands and I'll enter the room and greet the examiner, and then go to Arun and Arun. Hi Arun, I am Dr. Maya. Today I am going to examine you. How are you doing, Arun, today?
So Arun is fine as of now.
Okay. So I look at his faces. So I can find that he has got a very chubby face. Chubby face, and then I would like to ask for his height and weight. What about his height and weight?
Okay. Height is not well grown actually as per age, and weight is
Okay.
little obese as you can see.
Okay, and then I would like to look for the plot his height and weight, and then to calculate the BMA of Arun, and then I would like to ask the respiratory rate. And what about the respiratory rate?
Respiratory rate is normal.
Normal. Okay, then I'll take his hands and to look for whether is there any shortening of fingers or any short fourth metacarpal bond, anything like that?
No.
Okay, is there any excessive digits present?
No.
Polydactyly or anything like that?
Nothing.
Okay, what about the pulse rate? Is it normal?
Okay. That is slight tachycardia.
Okay, radical. Okay, and then I would like to plot his BP. And what about his blood pressure? Is it normal for age?
Yeah, little higher side.
Okay. And then on the face, I can see he has got a chubby face, and he is not wearing any spectacles. And then on the neck, is there any obvious swelling? I cannot see any swelling here.
In the neck there is no swelling.
Okay, is there any acanthosis nigrans present?
Yes, there is a capuchin in the back of the neck.
Okay, and then I would like to look for his. I think he has got gynecomastia present.
Yes, gynecomastia is not actually, that is related to this, just for.
Okay. Then I would like to do the abdomen examination. And is there any striae present?
Okay, there is stria also present.
Okay, and is there any scars like any hernia repair scar or any peritoneal dialysis scar, anything like that over the abdomen?
No.
Okay, and then I would like to examine his back. Is there any buffalo hump present over the back?
Yes, that is present.
Scoliosis. I'll like to ask him to touch his feet to look for whether there is any kyphosis scoliosis. Is there in present?
Negative.
Okay, and then I would like to. I'll ask him to do gait. Is his gait normal or any handling gait?
Gait is normal.
Gait normal. Okay, and then I would like to. After that, I would like to look for whether there is any edema over the ankle joint. Hello.
No edema.
Okay. Then I would like to do to assess his pivotal staging.
So pivotal staging is not. Pivoting is delayed.
Okay, staging is delayed. And what am I allowed to look his external genitalia?
Yes, external genitalia, you can see there is no such like definite hypothysis or hypogonadism.
Okay. So after that, can I summarize for now?
Yeah, please.
Yeah, today I have examined Arun. One second. What is his age actually?
10
Yes,
years.
today I will examine Arun, and 10-year-old Arun, and who looks over for his weight, and but height actually is below his well below his age, but I would like to plot on the BMI chart to look for his obesity or overweight. On examination, he has got a moon face and with acanthosis nigrans, and there is striae over the abdomen, and with BP on the higher side. On examination, and he has got normal gait with the delayed puberty. So my first diagnosis would be obesity. Most probably, this could be a case of Cushing syndrome from his facies. I think it's a case of Cushing syndrome.
So if this is a Cushing syndrome, do you think the child is well grown according to the both child? 10 years. She looks like short.
Short for his age, yes.
You finished your examination very early, but few of the other things in the axilla, you need to see whether any axillary hair was there or not. Okay.
Okay. Okay.
And any kind of lymphadenopathy was there or not. Okay.
Okay.
That is the thing. And in the hand,
Yes.
whenever you are examining the hand in an obese child, sometimes you need to do some of the maneuver like this. Ask child to stretch the hand and turn over, and some of the maneuver maybe just like make a fist, make a star. And so if you are telling the child, so do like this movement. If obese child taking some of the steroid for some of the chronic diseases, just like rheumatoid arthritis, maybe there is some kind of pain. Okay. Joint swelling. So all these things you need to assess. Okay. So the Cushing syndrome may be iatrogenic with exogenous steroid and endogenous. So we need to identify that what may be the reason behind that. Is it exogenous or endogenous? So for the child.
Okay.
So chronic illness is there or not. Maybe some of the other diseases as well. Yes, they're like Crohn's disease and some of the other chronic diseases. You need to check the oral cavity as well. Some of the gamma hypertrophy or maybe the obese child, some of the narrow airway maybe there, tonsillar enlargement maybe, or maybe all these things we need to know. So and third thing, we need to assess the eyes, because if this is a Cushing syndrome, then eyes may be affected because of exogenous steroid maybe. Okay. So cataract may be there, or some of the difficulty in vision, and checking the ear as well as like neck, short neck, so thyroid swelling is there or not. All these things. Acanthosis, you pick that. So actually that will be helpful in our exams in front of patient. Maybe some of the otitis media maybe.
Okay.
Some immune suppressed patient in such a taking long-term steroid, they may have recurrent like chest infection, ear infection, any infection is possible.
Okay.
So that's maybe some of the hearing aid also. You need to check all these things. And at last you need to check the gait as well as if this child is myopathic, like this lower limb is thin.
Yes.
And we ask the child, can you sit down and get up from this?
Okay.
Some kind of difficulty. And take your examination. After that, you just mention what we discussed actually.
Yes.
That is the examination. I'm not going into the Cushing syndrome in detail. Okay.
Yes.
We'll go on later. Otherwise, we'll detail.
Okay.
So, anything other thing you need to add here, please, which maybe I missed.
Yeah, no, I think you covered everything. Just central obesity.
Truncal and central obesity trial she picked up. But
liver should have palpated.
Yeah. But what I think, if our case looks like Cushing syndrome, it's better to avoid few of the terminology like buffalo hump. They say it's better to avoid. Okay, because some of the pad of fat is there in the back of it that can be used. Moon faces is better to avoid just round faces or something like that. Some of the hirsutism may be there in Cushing syndrome. The main thinking behind this disease or the case is what may be the reason of this Cushing syndrome, whether this is endogenous or exogenous. If this is exogenous, some of the chronic illness will be there with this patient. Okay. So basically that we need to find out. So maybe rheumatoid arthritis or maybe some of the other diseases. These are the things.
Is it essential to mention the waist circumference in these patients?
Head circumference only the significant where in maybe definitely achondroplasia, but which is short height only, not obese. But if we are commenting on weight, height, so it's always better to include the comment of head circumference.
And waist.
Oh, I really don't know. It's Dr. Neha can tell, I think.
You can say, but it is not needed. It is only endocrinologists will do it. Rest of the people will not. General pediatricians will not do it. So it is not expected.
Okay, thank you.
So that was our second case. So now, if anyone into let's say anything. No.
I think you've said everything, Pranav.
All of these recall cases. Anyone want to practice over this one?
I can practice.
Sure, Congress, sure. So whoever not willing to practice, basically the person is losing the opportunity actually. So without practice, that is very difficult, very difficult. So making mistakes here is more like important. Better to make mistakes here. Okay, Amrita, if you are ready, are you ready?
Yeah, I'm ready.
So if you are ready, then your time starts now. Please start.
Okay, so I'm entering the room and introducing myself by doing hand washing. Hello, I am Dr. Pankaj, one of the pediatric doctors here. Hi, Sapna, how are you?
Yeah, Sapna is fine.
Talk with me. Okay, can she talk with me? See, her meditation
she
is okay.
A little bit of not interested to talk to you right now.
Okay. So if her mother is or if parents are there, then I would ask for permission for examination and also to expose her to examine her.
Okay.
If that's okay.
You can proceed, please.
Okay, so I will look around. Anything, any ad, anything, any IV fluid or.
Okay, there is some of the bandages over the hand, as you can see. So just you suggest what may be the reason for this, like bandage over there.
Okay. So then I would examine for look for her growth and nutrition. She looks obese for her age and short for her age. So I would like to plot her height, weight, and head circumference on a age and sex appropriate chart, and also her BMI, and look at parents.
Yeah, sure.
Yeah, height. Okay, so she's obese, I think.
Yeah, the child is obese and short, and rest of the feature as you can see in the picture.
Okay. So I can see there is some generalized obesity, actually. See, generalized obese. So now I would like to examine her hands. Can she do like this so that I can look for any abnormality? Like I can see those fingers there, postaxial polydactyly is there.
Yeah.
It's her only.
Yes.
Okay.
Yes.
Okay. So apart from that, so in the this left hand, is this because of some sort of surgery?
Yes. Exactly. Exactly.
Okay. So I would like to ask her to do to make fish so that I can assess any other abnormality and
Okay. Yeah, making a
next
fist
step.
is difficult because of pain. Just operated. So
Okay.
otherwise, is making just a fist, and there is extra
Okay.
digit on both the side. Okay, so other side that is also present, and rest of the movement in the hand there is no difficulty for this child. Okay.
Okay. So I would examine her pulse also, if possible, on left side also, bilaterally
Yeah,
pulse for its
it's
volume character.
yeah, it's a high volume pulse.
Okay, it's high volume pulse. Okay, then I would move up and look for axillary hair if they are there.
Not present.
Not present. Okay, then I will move up for facial features, like she looks quite round faces with chubby cheeks, and other things are not quite obvious. Is there any other abnormality like eyes? She is wearing specs or?
Yes, she is wearing specs. Right.
Okay. Any abnormality of ears, any discharges, any hearing
Oh,
aid,
yeah,
anything?
discharges. And in
Yes.
the neck there is acanthosis.
Acanthosis is there. Okay. Then I would also examine for any lymph node in the neck area, and I
In the
would
neck
like,
there is no lymph node.
and anteriorly any thyroid, any swelling.
No
thyroid
thyroid
area.
swelling. No thyroid swelling.
Okay. Then I will come down and also examine, as she is exposed, I can examine her breast also for breast development.
Okay. Breast abnormality.
No, means part of pubertal examination.
Okay. So that is like not delayed puberty actually.
Okay. And then I would examine her. I will auscultate her apex,
Loud P2.
her right. Okay. Then I would also auscultate chest, against the respiratory sound bilaterally.
Yeah, that is normal.
Okay. Then I would come down and examine over abdomen, any stria or any
No
scar
scar,
mark
no.
is present.
No.
I would like to palpate also for any mass.
Liver is enlarged.
It's enlarged. Okay. So I would also palpate for liver span. Is liver enlarged? Span is also large. Liver span is also large.
Liver is also, spine is also bigger.
Okay. Okay. Then I would like to examine her. I would like to do the pubertal examination if I am allowed.
Okay.
So you said
Puberty
delayed
is
puberty.
delayed, so no need to like examine the genital.
Okay, so I would like to conclude my examination by examining her blood pressure, and eye examination, fundoscopy to look for any retinal changes, and plotting growth charts, BMI, with parental height, and compare with my parents.
So just present your
complete
case.
measurement.
Present your
Okay,
case.
so today I examined the 14-year-old girl, Sapna, who is having some typical features like round faces with spectacles on, with obesity and polydactyly in both hands and also in the leg, foot also. Yeah, so she is she looks like a case of some syndromic obesity, most likely this Lawrence Moon Bardet-Biedl syndrome.
Okay. So what will the other disease?
Other disease maybe of disease of syndromic obesity, syndromic obesity with polydactyly, like
Okay, okay. So how you will like investigate this child quickly?
for investigation, I would like to do the genetics study to rule out Lawrence Moon or Prader-Willi syndrome. Then also I would like to examine her limbs, hands for X-rays, hands and foot X-rays. Then I would like to examine eyes with endoscopy, and also some routine investigations for her obesity, like fasting sugar,
Yes, yes.
thyroid stimulating hormone, and
Thyroid.
thyroid stimulating hormone.
As this there is pivotal delay, so any other bloods?
Then hormonal studies.
Hormonal study maybe sometimes. Okay. So we will manage the case according to the like how you will manage quickly.
This will need a multidisciplinary approach. I have to involve my consultant also for the management, and basically it will need a pediatrician, and then orthopedician, geneticist. It will involve even psychologist also because sometimes for him yes, and as there is a relation about this, so the endocrinologist should also be involved, and also ophthalmologists should be involved because they may have natural skin. Then for regarding obesity, the dietitians and surgeons may be needed to be involved.
Excellent. So what it's 9 minutes over. So Pandita, you really did well, except one part, that is you have not checked the gait actually. Okay? So if the child is like having some of the skeletal problem, maybe in the hip or maybe in the other area, so yeah,
Obesity,
we find out gait. Otherwise, in the hand you check all these things. So before doing the maneuver, we need to ask the child, as you asked, there was pain in the left hand side of this operation. So again, the discussion before going in this kind of case, obesity with some of the scar for removal of the extra digit. So we will, if we look carefully over the hand, that will be visible. Otherwise, if we in a hurry, that is also possible that we missing the clinical finding. There was like extra digit, and now there is normal like 5 digit in each end, but the extra digit was removed. So we need to look very carefully whether any kind of scar is there or not in case of obesity, so that we can come to a conclusion. Okay. So that it may be a case of like this maybe. Okay. So rest of the discussion will be easier if we know the like complications details of obesity, and the investigation part we will divide into diagnostic investigation, maybe the genetic, and the rest of the investigation will be related to the complications of obesity. Everything, like including the blood sugar, lipid profile, liver enzymes, thyroid, renal sometimes. Okay, so all these things together, involving the cardiologist also, and all these things we will discuss. But before going to the next case, I will ask for the other people to give their feedback, so that will be complete. Okay. Any other feedback, please.
Actually, I don't know about Lawrence Moon. Few features I don't know. Some features only I know, like obesity and this polydactyly and some finding in the eyes. Apart from that, I don't know any other thing that I missed as a part of Lawrence Moon Bardet-Biedl as a syndrome. What other features are in?
We can have
Bardet-Biedl
retinitis
syndrome?
pigmentosa as is put it up in the picture.
Yeah.
So,
Polydactyly.
I thought you picked up because of the specs was there.
Yeah,
Because most of the common like major criteria diagnosis this kind of cases. This is
So
the one of the,
majorly will be obesity, polydactyly, retinitis pigmentosa,
yes.
and learning disabilities. That is the main thing.
Okay, then it's okay.
And rest of the minor criteria will just vary. Okay. Sometimes maybe
Nobody will
present.
remember that also. This is more than important. You know.
Yeah. We need to identify at least. Okay.
And
Okay.
when we are mentioning polydactyly, I think it's better to mention if it's preaxial or postaxial. In this Lawrence Moon-Biedl syndrome, it will be always postaxial.
Yeah.
That is very correct.
Yeah, that's great. So post-axial means not in like within the axis.
Postaxial meaning
means a small
Postaxial
finger,
means-
small toe side.
Preaxial meaning this side, the thumb side,
Yeah.
and postaxial
Yeah,
meaning little
postaxial
finger
means-
side.
Yeah.
Pre is
Yeah, I
before,
mentioned
post
that.
is after.
So there is no chance of getting extra finger over this thumb.
Yeah, in case of Lawrence Moon. And one more polydactyl, I forgot that name. Polydactyly is there.
So always that means this side will be the extra digit.
Yeah. But in
Oh,
your
postaxial.
picture, Pranav, the second picture which you have put shows preaxial also. See, the thumb has two fingers.
Yeah, second
Yes,
thumb
yeah.
is
So I don't think that is not a hard and fast rule where the polydactyly
That
should
can
be, but
even
we
vary.
should
But
mention it.
yeah.
no. I think that is also postaxial only. It looks like thumb, but it's postaxial.
Oh
only.
yeah.
Distal
Pankaj is
being
right.
little fingers.
Yeah, thumb is on the opposite side. That's
Opposite
little
side,
finger along with this. Yeah.
Yeah.
That's good information. Okay. So any other feedback? Otherwise, we can move for our next case.
I want to ask one thing. The leg, the knee position, is there any deformity or is there any problem in the knees of the child which is
Yes,
standing?
there is little what that called valgus deformity,
Valgus, some valgus
and
deformity.
that is maybe due to this
Because obesity.
obese child also have
High.
some of the vitamin D deficiency. Okay.
Okay.
So maybe that is the reason, and even some of the skeletal dysplasia may be associated with this kind of syndrome. So that is.
And is the lower limb kept externally rotated in this child? Is it or is it normally placed?
No. Actually,
Normal.
even I have collected this one from the internet only, so I really don't know about the detail of this case. But what you just just observing, I am also seeing the same thing.
Yeah, I observed, but I forgot to tell. But this should be mentioned actually. Whatever that is quite obvious.
Some
that
of the
may be because of obesity.
And Dr. Pranab, the upper picture, the B picture, the skin has been stretched. Is there any clinical findings, or is there any other clinical findings?
No, I really don't know. Maybe they are showing both the hands only and the fingers. Okay. Because of this
pressing just to show basically small child.
Yeah.
Okay.
Because if there is extra digit, if this digits are usually floppy. Okay. So they will just go down beneath the another palm. That will be difficult to take a picture. So maybe that reason they are just keeping in this fashion so that the extra digits can be seen. Okay. Okay, so now we can move for our next scenario. This is the last scenario. After that, we will go to the discussion of obesity, basics, complications. That will be easier to remember. After that, a quick review of guideline, and that will be more important and easier to remember. Okay. So this is the last case, last scenario, please.
Can I do this?
Yes, sure, Dr. Deepa. Sure. Sure. So
Okay,
whenever you are ready, just let me know so that I can start. Okay.
Okay.
So
So,
ready.
okay.
So your time starts now. Please.
I'm entering the room. I'm washing my hands. Hi, I'm Dr. Deepa. I'm one of the pediatric doctors. Chris, how are you today?
Yeah, I am fine.
Are you going to school, Chris?
Yeah, I'm going to school, but lots of friends are just making fun of me. Actually, that's why I'm very much depressed.
Oh, that's very sad to know, Chris. May I examine you today?
Yeah, sure.
Do I need a chaperone to start the examination, sir?
Okay, no. You can examine him.
Okay, thank you. I'm looking at Chris. I'm looking for any distress or
No distress.
any abnormal features on his face.
There is no abnormal
apart from
feature.
what I can see. Okay. Is he hearing any? Is he using any hearing devices or any glasses?
No.
I would like to know his height, weight, and head circumference.
Okay.
Is it normal?
Is it age appropriate? Height is age appropriate, and weight is little overweight, as you can see.
Okay.
Yeah.
I'm looking at his parents for any similar features or any abnormality.
No.
Is his parents normal?
Normal.
Okay. I'm generally looking at him. I can say that he's peculiar. He has got a peculiar distribution of fat with gynecomastia, and there are not much skin changes. I'm looking at his hands. Can you show me your hands, Chris?
Yeah. He's free.
Can you make a star for me?
Yeah.
Like this?
Yeah.
Yes. Is there anything abnormal in his hands? Any extra digits or any scars?
No scar, no extra digit. He is moving.
Can you make
normally.
a fist like this? Can you make a fist?
Yeah, there is no problem.
Is he moving his hands normally? Is any
Normal.
short digits or anything? Nothing like that. Can you move your wrist up and down like this? Is he able to move his wrist?
Yeah, there is no problem.
I'm just palpating his pulse. Is it normal?
Yeah, little high volume pulse is there.
No. And together with that, I'm checking his respiratory rate also. Is it normal?
Respiratory rate is normal.
I think my net is not good. I'm looking at his. Can you raise your hands, Chris? I may see your axilla.
Yeah.
Is there any signs
he
of
is
puberty?
raising that. Yeah, there is no axillary lymph node. And what else you want to see? Axilla, there is no axillary lymph node. Any other thing you want to see? Is that my problem or her?
You are disconnected or?
Connection is looking to. Okay. Yes.
She got disconnected, I think.
Okay, I just escaped. The time.
I'm really sorry. My net is not.
Okay, no problem. There was pause.
Can you hear me now?
Yeah, it's clear. Now you can continue from the axilla. Okay.
Okay, so there are no signs of puberty, see, and now I am going to examine his head. Shape and size seems to be normal.
Yeah.
And is there any hair changes?
Yeah, just in the scalp there is normal hair, and as you can see in the picture,
is his eyes normal?
Eyes is normal, yes.
Normal, no cataract, no shape difference, nothing.
No.
I am looking at his mouth for any abnormality, any high-ash palate or tonsillar hypertrophy, anything?
No, just long faces, and there is no high hair palate. Dentition is also normal, and no big tongue or nonsense is normal or within oral cavity. Okay.
Hello?
Yeah, I'm just waiting.
I thought I got cut.
No, you are here. So
He's reconnecting, I think.
I think that was, like connection error maybe.
Yeah.
She is unable to continue, I think. Anyway, any other person want to continue if she is not joining? Then
I can continue if nobody's continuing.
okay, sure, please continue.
I forgot where she stopped.
Actually, over the face.
I can
Oh,
see
she's
some
back. She's
acne.
back. I think
Okay.
she's back. Just wait.
Okay, then I won't say anything.
Hello. Can you hear me now?
Yeah. Now it's
I'm
clear.
sorry, my net was not.
Okay. No problem. Please continue.
Okay, so I'm looking at his mouth for any abnormality. Is there anything?
No. Negative.
Now I'm looking at his neck for any thyroid swelling, any
No.
acanthosis,
Negative. Nothing.
any lymph nodes I'm palpating.
No.
Looking for any scars.
No.
So now I'm proceeding to examine his axilla for any lymph nodes, and
No.
I can see that he has got gynecomastia bilateral, and is there a pectus excavatum?
No.
Is it apparent because of the gynecomastia? Okay.
Yes.
Now I'm just palpating his apex beat and looking for any right ventricular heave. Is there anything?
No right ventricular heave.
I'm just auscultating for his heart sounds.
Loud P2.
Loud P2. Okay, thank you. So now I'm going to palpate his abdomen. Do you have, if you have any pain, just let me know, okay?
Okay, sure.
Okay. I'm looking for any hepatomegaly or any abdominal
Yes, liver is
masses.
enlarged. Yes.
How much?
3 centimeter below the costal margin.
Is it soft?
Soft.
With smooth surface?
Smooth surface.
Okay. Is the left lobe palpable?
Yes. No need to go to detail.
Yeah.
Not
Thank you. No other abdominal masses are palpable?
No other abdominal masses.
Is there any striae over the abdomen or anything?
If you see the abdomen very carefully, then you will find out some of the features also.
Okay. Am I allowed to examine his genitalia?
Okay, the genitalia is not allowed to see in the exam, but I'm giving you the finding. There is just scanty pubic hair, and
Okay.
test to the hypogonadism is also there.
Okay, thank you. Can you just walk for me, Chris?
Yeah, he is walking normally.
Yes. Can you just sit down and get up?
Yeah, there is no problem.
There seems to be no abnormality with his lower limbs. There is no bony abnormality or any positional problems.
No.
And I think there are no scars also.
No.
Can you just turn around? I can see your back.
Yes, sure. There is
there any
scoliosis.
Scoliosis is there. Okay. Can you just bend down and touch your toes?
Yes, yes. The scoliosis is disappearing.
Disappearing. It is positional.
Also.
So, is there any length discrepancy?
No, no.
So I would like to do a hip examination. Time is over?
Yeah, now it's over. You just
Okay. So I would like to complete my examination by doing a
Love you, Baba.
hip examination, taking his blood pressure and taking his urine for a dipstick test for blood sugar. And yeah, I think I would like to plot his height, weight, and BMI on the chart also.
so what is your most likely diagnosis? Regarding what
with the findings,
whatever is your finding, which is correlating your diagnosis.
okay. Today, I have examined Chris. He's a 15-year-old boy with delayed puberty, and he has got hypogonadism with obesity, and there is a evidence of pulmonary hypertension also, because of sleep apnea. And with these findings, I think he may be a candidate for Klinefelter syndrome, but I will have to confirm it with karyotyping.
What will be the result of karyotyping you are expecting?
Excuse me?
What will be the finding of karyotyping?
There will be XXY, and analyzing the sex hormones, there will be an extra X chromosome.
Okay. So how will you investigate this case apart from the study? I'm sorry, karyotyping.
To investigate this, I will confirm the diagnosis, and after that, for the hypogonadism part, I would like to do his sex hormones, FSH, LH, and testosterone and dihydrotestosterone levels. And for the basic tests, I will do a full blood count and urea and electrolytes, and LFT is important for this child because he has got a hepatomegaly. Liver function test I will do in detail, and an ultrasound examination of the liver to assess the cause of hepatomegaly. And I think it may be because of fatty liver. I would like to grade the fatty liver also. And
okay. So,
okay. I would like to examine his hip. After the hip examination, I would like to take an X-ray also, because he's having scoliosis, and I think he may have some vertebral problems also that will be evident in the X-ray.
So how you will manage this child?
He needs a multidisciplinary approach with the involvement of a pediatrician, endocrinologist, a dietitian, physiotherapist, orthopedic surgeon, and he seems to be of a normal mentation. So I think school support may not be necessary, but
no. Actually, mentally normal, but IQ level is not good enough. Some of the dyslexia or maybe the learning difficulty will be there.
Okay. After detailed analysis, we will decide if he needs some support or not. Otherwise, actually, I don't know much about the complications.
Okay, so that is the area I am just trying to tell you repeatedly. The case is basic thing is obesity, and the background, there may be some of the syndrome like this. Okay, Klinefelter, maybe bubble bigger, maybe some other like what we discussed today. So every syndrome will be some separate positive factor, maybe genetic or maybe some other reason. But whenever we are managing the child, we need to include this obesity part as a management, because that will be more easier. Okay, now what I am telling from the very beginning today, we will discuss the basic of obesity. So that will definitely help in the like management or investigation part. Okay. What I believe, if we know why this is happening, that will be easier to remember. If we, try to remember just like ratta, so that will be, like very difficult to remember.
What we are doing?
We are
What?
quickly going into the discussion of obesity, the basics. After that, we will just see the guidelines very quickly. Okay, just very fast. Okay, and that will definitely help us to remember, because the syndrome may be anything, but the obesity, whenever this obesity will be there, na, so basics will be the same, more or less same. Okay. So obesity, if we see some of the comorbidities or the other complications will be there. Now, the cardiovascular system, what we know already know, hypertension. Why hypertension will be there? The question is why. Okay, if we know all these things, that will be easier to remember. So, some of the increased sympathetic activity will be there. For this system, aldosterone and angiotensin system will be activated in this obesity group of child. So that is just one reason of the high blood pressure. Okay. Now, in addition, there may be increased catecholamine level also. Very quickly, I'm going. Okay. Now, some of the coronary artery disease is also possible because of co-complications like diabetes, hypertension, as well as dyslipidemia and sleep apnea. So all these are related to coronary artery disease. Okay. Now, heart failure. Some of the cases, there may be right-sided failure due to sleep apnea. Okay. Now, atrial fibrillation also most common cardiac arrhythmia, and that is life-threatening sometimes. Okay. Stroke is also possible because of increased EMI, as well as, if there is like PCV is very high, there is hemoglobin concentration because of like obstructive sleep apnea maybe, or raised PCV level, maybe stroke is another possibility. Venous thromboembolism at the same time, 6-fold increased due to hypercoagulable state, which is mediated by adipokine. I'm not going into the detail. This is very detailed, so not needed basically. Okay. So there is chance of thromboembolism also. Respiratory complications, what? This is very common. There is obstructive sleep apnea, very, very common in obese children. Okay. Is this sometimes all this factor is responsible for this? That is insulin resistance, dyslipidemia, and hypertension, coronary artery disease, and later OSA, and the independent factor for this respiratory as well as cardiac complications. Okay. Now, Dr. Neha, you were asking at the time, what is Pickian syndrome, na? So this one, mentioned in a just short one line. That can be, you can Google it and have an idea a little bit of more. So this is obesity hypoventilation syndrome. Obesity related to hypoventilation in a way that the PCO2 level in this group of children will be higher side. They are like hypercapnia will be there. That is sleep disordered breathing. Okay, and they are chronically adapted with this kind of condition. For this reason, renal compensation will come to act, and bicarbonate level little bit of higher side will be there. So this is the basics of this syndrome, and you can have a little bit of more information if you want. Just read it from the Google. Okay.
Okay, I don't think that it is required beyond
this. Is not required, but just for knowledge, for your knowledge actually. You can have a good article to read it out. Okay. Now, endocrinology, which is really important because type 2 diabetes is always, there is chance to like 80% cases with obesity that is related to insulin resistance and getting like diabetes like disease. So The defect, I'm not going into the detail again, the defect, why this is getting. But insulin resistance will be there, and dyslipidemia, 70%. Again, elevated load, like dyslipidemia will be there, okay? So LDL will be high and ADL will low, all this thing will be there. Metabolic syndrome, truncal obesity, dyslipidemia, hypertension, all these things with glucose impaired fasting of glucose, all these things will be there. Vitamin D deficiency in obese children, sometimes definitely low concentration of vitamin D may be there. Okay, so that's why deficiency is very common in obese children. Another complications, that is neurological. In case of female, idiopathic intracranial hypertension, very common, headache, pseudotumor cerebri. Okay, so if this is a chronic headache, then we can see the fundoscopy, through this fundoscopy, whether if this is not acute, if this is chronic, then papilloedema may be present. Okay. Now, musculoskeletal arthritis, because of this heavy weight, okay, that is dependent on the compression over the weight-bearing joints, like knee, okay, or ankle sometimes. So that is osteoarthritis. Arthritis is also possible. Now, obese individual more commonly experience some of the fracture also because of this. Fracture also because of this weight, as well as souffle. Okay. So these are the gastrointestinal non-alcoholic fatty liver disease. That's why the fatty liver will be enlarged. Okay. Now gallstone. So why I am going into the detail of this information? Because if this obesity comes in history-taking management planning station, we can correlate the like information or clinical finding with this like topic. This is really important. That's why. So if the obese child is present with pain abdomen, sometimes there is chances of getting this gallstone also. Now gastroesophageal refluxes also. Okay, that is also very common problem. And this reflux is, if this is chronic, then maybe stricture or Barrett esophagus or esophageal carcinoma is also possible. Urinary tract, including the chronic renal disease or kidney disease, is also possible. Okay, so I'm not going into the mechanism, but some of the chronic inflammation is there. That's why this rash is activated and blood pressure will be high. At the same time, chronic renal disease is a possibility. Reproductive system in obese, what will be? The reproductive system like hypothalamus and pituitary ovarian axis obesity. So irregular menstrual cycle, ovulation defect, and infertility, increased risk of miscarriage, endothelial dysplasia, and PCOS. Okay, all these things. Psychiatry, definitely. Depression, maybe dementia will be there. Okay, psychiatric disorder in this obese patient is also possible. Now, this is skin manifestation. That is, some of the children with obesity have like poor in wound healing and repeated skin infection and skin changes like hirsutism and acanthosis nigrus. All we have discussed. Infection is also possible, as we just discussed, in the skin. Now neoplasm, I'm not going into the mechanism why this is possibility. This possibility is, what are the chances of getting what types, that is esophageal carcinoma, gastroesophageal cancer, colorectal cancer, hepatocellular carcinoma, colonial carcinoma, peptic cancer, pancreatic cancer, and all this cancer is also a possibility. Okay. Now that will be helpful if we go into the guideline. Just exactly, they are mentioning the same thing what we just discussed right now. Okay. So obesity cases, if this is a history taking station, then we need to know. So if this is overweight, that is more than 91 centile, and very overweight 98. Also, all these are basic, we know. And history taking, okay, for there is it's already late, so I'm going directly into the management section. Okay, so investigation in the short clinical, that will be very helpful. What are the investigations they are saying? That is, for all the cases of obesity, urine for dipstick for the glucose. Okay, this is most easily like available and can be done at bedside. So if the examiner says just what are the like investigation or how will you manage or what are the tests you can do at bedside in obesity child, then we can say that yeah, urine dip, taking the blood pressure and pivotal assessment, which is like can be done at the bedside in case of obesity. Now, rest of the investigation is thyroid function test, glucose, random glucose, and if it is raised, definitely there is chance that the blood flow will be high, then glycosylated hemoglobin. Lipid profile, as there is chance to get deranged lipid profile, and liver function test. SGOT, SGPT will be in the higher side. This is fatty liver. Now, this is the first line, and every cases we need to do this basics blood test apart from diagnostic blood test. Means if the case is Prader-Willi or some of the burden bit, any genetic test may be needed, and that will depend in a separate like to diagnose this case. That can be given to the examiner this piece of information that I want to like confirmatory test. I want to do this one, but as you can see, these all common cases, common investigation are applicable in every obesity, every obesity. Am I right? Nobody will reply.
Yeah. Oh, yeah, correct.
Yes, this can be done in all.
This part. So that's why I just said at the beginning that obesity, if we understand the basis of obesity, that will be easier. So all the cases of obesity, maybe syndromic or maybe non-syndromic, maybe simple obesity, this part of investigation is very common. We can do all this investigation for any type of obesity apart from the diagnostic test. Okay. Now, second line of investigation is, so what we are telling till now during our practice session, we are telling the diagnostic test at the beginning, but that is, we can change a little bit. For every cases of obesity, we can include this first line of investigation. After that, if the examiner asks what will be the other test or maybe the diagnostic test, then according to the case, we can say some of the genetic states or maybe the chromosomal study or something like that. Okay. Or if there is any like features of Cushing syndrome, then we can do some of the like specific tests to diagnose the Cushing syndrome, and maybe like your dexamethasone suppression test, like cortisol level, all these things. Okay. So now ambulatory blood pressure. So single blood pressure usually not reliable. Okay. So that's why they say ambulatory blood pressure is important. And as this group of children, like pseudo parathyroidism, they are also there is chance to getting obesity. So phosphate and calcium is also important to the second line of group of investigation. If growth failure means short height, then we can, and hirsutism and hypertension, that is indicating of Cushing syndrome. At that time, 24-hour urinary cortisol can be done. And if you suspected the ovarian syndrome, that is PCOD, then rest of the investigation can be done. And sleep study, which is very important. This one we must say in the exam, okay? Because sleep study is like there is chances getting like OSA. So yeah, treatment as we can see, the first line of treatment is like to weight management program, there is dietary advice and exercise. So diet, lifestyle modification, these are the first line of investigation. So every cases after that, like bariatric surgery, if this is morbid obesity, okay. And rest of the part of management, again, you can see all this management part is depends on the complications only. Complications. See, this type 2 diabetes, again, pediatric endocrinologist will involve, some of the metformin can be given, and rest of the management like microalbuminuria, again, we can involve some of the pediatric renal team, means nephrologist and endocrinologist, if there is diabetic nephropathy is developing or not. That is the thing. If any kind of nephropathy is there, we can use SE inhibitor. Okay. Hypertension, if there is hypertension, we can take permission, I mean, the opinion of cardiologist, and again, first line diet management and exercise, all these things. After that, medicines. Dyslipidemia, that can be also corrected with some of the medicine, like statin group of drugs. If this is a fatty liver, then we can take the opinion of hepatologist maybe. Okay. So all these are the part of complication that we already discussed, that is given in the guideline nicely. So if we know the disease very well with the complication, that will be easier to manage the child in the exams. If there's sleep apnea, again, ENT specialist opinion. And if there is depression, definitely that is child and adolescent mental health services we need to involve. And we need to monitor the child. That is the end of the story. Okay. So this was really lengthy, but if we just follow the guideline a little bit, that will be more easier to present the case in the exam. Okay.
Yeah.
Okay. So it's already late, I think. That was a long discussion. It's really late. Okay. So when
Tomorrow is
time goes,
Sunday.
anyway.
Yeah, today too many discussions. We did
Yeah.
so many cases and then.
So what we left, that is growth chart. Again, we'll try for cover it tomorrow maybe. So
And also thyroid.
thyroid gland. So Dr. Neha is left, I think. She is doing the thyroid. Okay. So guys, see you tomorrow. Till then, just have
See
a
you
look
tomorrow.
on the See you. Take care. Bye bye. Good night.
Bye bye. Good
Good
night.
night. Good
Good
night.
night. Good night. Thank you. Thank you.